All right. Autumn, Emily, can one of you see my screen? Can you confirm?
I can see it, Chris.
Okay, yes. Wonderful. All right, well, thank you everyone so much for hopping on during your lunch hour today. We are thrilled to be hosting the ABOA Minority Cancer Awareness Forum with some very distinguished speakers. April is Minority Health Month, so this is a very timely topic that we are going to discuss. It's going to be very conversational too, lots of time for Q&A. Regardless, we are just thankful for you spending the time with us today. And so to kick it off, I'm actually going to pass it over to our ABOA president, Emily Fitzgerald.
Hi, everybody. Thank you so much for joining us today. We are thrilled to have you all here. So what many of you may know is the ABOA is very committed to diversity, equity, and inclusion in our members, the areas that we serve. And so Minority Cancer Awareness Month is really just very near and dear to our hearts. What we do know is that cancer affects all of us here, but it doesn't affect us all equally. So today and all of the work we're doing is really about exploring this and what we can do to change that and really make meaningful impact going forward in the future so that we can, one day say that it doesn't affect us at all, but it's more of an equal factor, and that your skin and your heritage don't dictate your outcome with cancer. So with that, we're thrilled to have you here today, and thank you so much for joining us.
Wonderful. Thank you, Emily. All right, Autumn. So off to you.
Hi. Thank you so much for joining us today. Not sure where in the country that you are joining us from. This is a Chicago-based associate board, and so we welcome you to be a part of the conversation about how cancer impacts multicultural communities throughout the US, and then also a Chicago emphasis. My name is Autumn. I am the ABOA DE&I director for the Chicago-based associate board. I professionally work as a DEI program manager in recruiting for Meta, formerly known as Facebook. I joined ABOA as a part of sharing my mother's story and how I believe that earlier education, earlier prevention could have prolonged her life and even increased her chances of survivorship. So it's really important and that we share in that storytelling about how cancer has impacted us individually or people we love, and ensuring that we can give back and reduce these disparities that we're going to discuss today with Dr. Nita Lee, as well as Michelle Hicks Turner. So it's my pleasure to just give you, I think on the next slide, just a really quick overview of what DE&I covers with the associate board. Our primary purposes can be categorized in 3 areas. The first is supporting board membership. So the really cool thing that our committee enhances is all facets. We are working alongside with sales, events such as this one. We are working alongside with membership to ensure that not only we have an inclusionary member experience, but also that we are diversifying our streams of fundraising, as well as diversifying board membership. And then my particular passion, and also what drew me to ACS ABOA, is sharing awareness about health equity through a cancer lens. So that's what we do, and that's what we offer. It is now my pleasure to actually introduce first to the conversation, Michelle Hicks Turner. Michelle Hicks Turner is a cancer control strategic staff partner with Cancer Control Strategic Partnerships. She's a manager with the American Cancer Society. Michelle and the Illinois Cancer Control team strive to approach population health by reducing the burden of cancer through systemic implementation of evidence-based interventions with hospital systems and FQHCs, which are federally qualified healthcare centers in Illinois. Michelle holds a Bachelor's of Science degree in Occupational Therapy from Chicago State University and a Master of Public Health degree from St. Xavier University. Michelle is passionate about improving the cancer burden among minorities through evidence-based cancer prevention strategies and promoting health outcomes for future generations. Michelle resides in Southwest Chicago suburbs with her loving husband and energetic 8-year-old miniature schnauzer. Awesome. Well, welcome, Michelle. Thanks for joining us.
Thank you for having me, Autumn and Emily, and thank you, Autumn, for sharing your cancer connection with us today. So happy to be here. So next slide. I'm going to start. I know it's afternoon and you all are probably having your lunch, but I just have one pop quiz for you today, a true and false question. We're going to talk a lot about health equity and health equality, but my question for you today is, health equity and health equality, are they the same? True or false? Feel free to put in the chat and Chris will let me know. Give you a second to answer. Oh, I see a lot of false. Excellent. If your answer was false, you are correct. Thank you. Next slide. Right, so Emily mentioned earlier that cancer is a disease that can affect anyone, but it doesn't affect everyone equally. There are many social structures and practices that can limit a person's access to healthcare needed to prevent, to treat, and to survive cancer. These obstacles may include racism, discrimination, poverty, lack of access of healthy and affordable foods, low quality education and housing, and jobs with inadequate pay. When the quality of healthcare differs from people because of racism or other forms of discrimination based on their income, based on their health insurance coverage, their race, their ethnicity, their gender identity, their age, even disability status, it's all called health disparities. And healthcare disparities can affect every step of the cancer care, from the prevention, the screening, to the quality of life after cancer treatment, which means the disparities in care can affect whether a person lives or dies from cancer. Next slide. So we're going to talk a little bit about the cancer disparities here. You see the image here that I borrowed from feminists in India, but it was a nice image that I like. It's a nice image of equality and equity. And you see what equality, all the crates are the same, but in equity, some crates are higher and some crates are a little bit lower. But that's what health equity is. It's quality, health equality is equal treatment and availability of healthcare services for all people. Whereas health equity is where everyone has an equal opportunity to be healthy as possible. And that's the example that you see in the equity picture there. So when we're talking about cancer, equity is when everyone has an equal opportunity to prevent cancer, find it early, get proper treatment, and follow up after treatment is completed. Next. So I just want to share an example of ACS CAN, which is our advocacy arm of the American Cancer Society. We have a lot of wonderful resources for anyone. And this is one that I like in the lens of cancer disparities and through health equity. It is a chart book. It illustrates the scope of the cancer disparities that exist across our nation. And then also shares what they're actively pursuing, these evidence-based policies on local, state, and federal levels that seek to reduce these disparities and improve health outcomes for all U.S. population, regardless of their race, ethnicity, gender, age, sexual orientation, social economical status, and zip code. So I would highly recommend for you to view this chart book. You can view it on ACS, or you can go to cancer.org and then or fight back cancer or fightcancer.org. Next. So now I'll tell you a little bit more. Autumn mentioned that I am a Cancer Control Strategic Partnership Manager. And what we do a lot. We're on a mission across this nation here. And our North Star is to reduce cancer mortalities by 50% by 2045. So, and we do this because we want to ensure equitable experiences, outcomes for all, ACS cancer control. And we do it with our providers, our hospitals, our health departments, insurers, employers, and the state to establish policy, funding priorities, and implement quality and systems initiatives that deliver results. Overall, we focus our work where it's needed most to create measurable and meaningful impact and reduce disparities. And just an example, recent example that what we're working on now are transportation grants. In September 21, the North Central region invested about $400,000 in patient transportation grants to 35 health systems to provide rides for individuals that were actively in treatment. And then in Illinois, we provided 7 grants and 525 individuals were impacted with that grant, and 5,410 rides were presented. And we were able to utilize $44,000 of that funding. So that's just a small example. There are many examples of what the cancer control team does to provide these measurable and meaningful impact to reduce the disparities, because we know and we've heard that transportation is a barrier for some people to receive treatment. Next. So with the American Cancer, or not the American, I'm sorry, the Cancer Control Team, we take on a population health approach. And this diagram here from the American Hospital Association is just a diagram of population health framework. It's pretty loaded here, as you see here, but I just want to define a little bit by what we mean by population health. Now, the CDC, which is the Centers for Disease Control and Prevention, they view population health as an interdisciplinary, customized approach that allows health departments to connect practice to policy for change to happen locally. So the population health, it is an approach to health that aims to improve the health of the entire population and to reduce health inequities among population groups. So for example, here, understanding populations. With our team in Illinois for cancer control, we are data driven. We look at the data where we're looking at Cook County, or we're looking at data from Central Illinois. We want to understand the population. We want to understand where the disparities lie, where the cancer incidence rates lie. And then we connect with our various of health systems and health departments to really look at that at a system level approach. So that's just an example. I won't, for the sake of time, I'll go into the weeds of population health, but I just want to give you a snippet of what population health approaches and how cancer control does it. And at the center of that is health and equity for all. Next slide. I also want to spotlight our ACS research publications through the lens of health equity. So we have several here. We have Dr. Islami and what he's working on, the state of cancer disparities in the United States. And what he focused on his research, I just want to tell you what he is too. He's a senior scientific director. He's a cancer disparity research, ACS surveillance, and health equity science. And what he quoted from his research that he did was that despite some progress in recent decades, cancer disparities are still a major issue in the United States. And they may further widen because of the increasing costs of novel treatments and advanced medical technologies. Much work is needed to be done to enhance health equity and mitigate cancer disparities. And that's from Dr. Islami. Now we have Jingshua Zhao. She is the ACS Associate Scientist in Surveillance and Health Equity Science. Her study is on when more people qualify for Medicaid, more cancer survivors. And what she gave a quote for us was that we constantly found a link between lower Medicaid eligibility limits and worse survival after a cancer diagnosis. And that was true whether the cancer was found in the early or late stage. So this can be explained for multiple reasons. Having health insurance may take receiving guided-based treatment easier to receive and complete, and may improve access to timely care as specialized survivorship care, psychosocial care, and end-of-life and hospice care. And then we have Dr. Cheryl Knott. She did a study on community health and advisors and church. And what she does, she's from the ACS grantee from the University of Maryland School of Public Health. They train lay individuals in the churches to serve as community health advisors. So these are the regular folks who are in the church. They don't necessarily have a health background or specific health training. And they go through a 13-module training and certification process so that they can become and play a major role of the community health advisors and the church. Then they can become the peer that most people trust and can go to for cancer info. They conduct a lot of series of educational workshops. So that was her study. And then lastly, you have Dr. Mark Linzimbi. He is a ACS grantee from Yale University. And he did a study on achieving cancer health equity in the Muslim American community. And he quoted that we found this in some of our participants, the belief that God is punishing the person for past deeds by giving them cancer. And this is not only unsettling for cancer for patients, but it's also unsettling for providers. So how do you approach this and not offend the person? How do you turn it around from persecution to an opportunity for meaning making? So this is something that if you want more details about their research, I advise you to go to cancer.org. Next. I know it's pretty tiny, but there's a lot of resources for health equity resources, and they can be categorized in advocacy. The one I mentioned earlier was the Cancer Disparities Chart book. Then there's discovery and research. We have cancer facts and figures for African Americans, cancer facts and figures for Hispanics, and now we also have that document in Spanish. Also, there's information about understanding and addressing social determinants and advanced cancer health equity in the United States. There's patient support. There's the facts on our fight, making the case for health equity principles, the inclusive writing guide, how to write if you're putting messaging out on social media or in print, how to utilize that health equity language in there. And then also, again, you have our ACS patient support programs and services. Next. And I'll leave you with a quote from our CEO of the American Cancer Society, Dr. Karen Kneeson. And I love her quote here. And she said, in short, we're leading the fight against cancer that benefits all and walking the talk in every aspect of our organization. I am proud of what we have achieved so far, proud of what we planned, proud that the American Cancer Society is the leader in leveraging advocacy, discovery, and patient support to bring about equity in cancer prevention and cancer care. Thank you all for listening. Thank you for your time. Thank you for your interest in health equity. And we really appreciate your partnership. Thank you so much.
Yeah, thank you, Michelle. Really appreciate the insights here. I had a couple of follow-up questions, and I think I saw one in the chat we can address. Love the quote. I use it frequently. Cancer is a disease that can impact anyone, but it doesn't impact everyone equally. And so the question should be clear so we all understand. If you don't mind outlining us, which populations are at highest risks of cancer incident and survival rates?
Unfortunately, it's African Americans. They have the highest incident rate, and then second to that would be Hispanics, depending upon the type of cancers. I know with breast cancer, it's highest among African American women and even affecting them younger. So it is an issue for us. And how our cancer control, me specifically, is addressing it. We have recruited a legion of women. These are wonderful women, about 42 women from the Akarama Foundation. They're part of the AKA sorority. And it's similar to the research that Dr. Knott was doing with educating women about the importance of breast cancer screening. We're actually going into those populations in those communities that have high incident rate to educate them about the importance of breast cancer screening. So that's just one example of how we're attacking cancer for those individuals that have a high cancer incident rate. I hope that answered the question, Adam, for whoever asked it. Thank you.
Yeah. Yes, absolutely. And then one more from me, and then we'll go to the chat. And it's not just inherently because of one's ethnicity or race or where they were born strictly dictates where their cancer incident rates and these outcomes. But there's other factors like socioeconomic factors, and ACS outlines through the cancer in the cancer disparities chart book that you reference, as well as other research materials, that there's social determinants of health, and you definitely referenced it earlier. I certainly saw the connection and how your team is prioritizing bridging gaps with transportation, as that's a barrier to cancer treatment. And transportation is one of many social determinants of health that disproportionately impact the Hispanic Latin community being underinsured, similar to the LGBTQ community, as well as African Americans having lower access to transportation and treatment. Can you just share with us a few more of those social determinants of health that impact certain communities that don't impact others?
Yeah, sure. I mentioned one about food deserts. Food desert is where people don't have access to fresh food or fruits and vegetables. That we know nutrition is one way, as a preventative way to prevent cancer. And so how we address it from Cancer Control, and we have partnered with Factor Meals, and they donate meals to 22 of our healthcare systems across Illinois. And even now we've reached out to southern part of Illinois, like Rockford, Illinois. And so we partner with these health systems because they've identified some food insecurity, which is a social determinant of health as well. So they've identified as food insecurity and among their cancer patients in active treatment. And on a weekly basis, we can deliver up to 20 to 60 meals a week to those hospitals which are a few of those 22 hospitals are safety net hospitals that really provide services for a underserved population. And so they're able to provide these fresh foods to these cancer patients on a daily basis. So that's just one example when we talk about those social determinants of health. Transportation is one. Another example could be just access to care. Recently, we partnered with Blue Cross Blue Shield of Illinois, the big insurance company when we talk about insurers. But we also partner with them as they opened up these new Blue Door neighborhood centers. And they reside in the communities where there's high incident rate of cancer, and they're one in Morgan Park, one in North Lawndale. So my colleague and our Aubrey, we partnered with them to provide colorectal information, called the importance of colorectal screening. But we know the American Cancer Society that colonoscopy is the gold standard, but some people don't have adequate insurance to cover colonoscopy. But we can provide them information about a FIT test, which are a stool-based test. And so we were able to come into those two communities, provide education to that community, but also inform them about the importance of stool-based tests are just as good as getting a colonoscopy. And then also informing them of where their primary care, what we call FQHCs, federally qualified healthcare centers, are located in that community within a 5 to 10 mile radius. So that's just an example, Autumn, how we look at the community that we're serving. We look at those social determinants of health, whether it's access to care or inadequate insurance, and try to provide resources for them to connect them to the right resources that's going to get them to their proper screening and have it to be affordable as well. I hope that answered your question, Autumn.
Yes, absolutely. Thank you, Michelle. The question that we'll take from the chat is actually a perfect segue into Dr. Nita Lee's segment. And Jeff's question is, what are the impact metrics that ABOA is using for equity in the Chicago area? And she's actually going to localize this for us and walk us through that. I'd like to introduce, though, Dr. Lee, just so we understand the amazing work that she's doing and making an impact in Greater Chicago. Dr. Nita Lee is a gynecological oncologist at University of Chicago who specializes in the diagnosis and treatment of women with gynecological cancers. Her focus is on providing comprehensive and compassionate surgical, chemo, and survivorship care to women diagnosed with ovarian, uterine, cervical, vulvar, and vaginal cancers throughout their cancer journey. Dr. Lee serves as the University of Chicago Comprehensive Cancer Center's Assistant Director of Community Engagement. Through this role, she supports ongoing community collaborative education and research to reduce cancer disparities in the surrounding Chicago communities with a personal focus in breast and gyno cancers. At the national level, Dr. Lee is the chair of the Patient Education Committee of the Foundation of Women's Cancer and a member of the American Society for Clinical Oncology Survivorship Committee. So thank you for joining us, Dr. Lee. Really appreciate you carving out time out of your busy schedule to be with us.
Thanks so much. That was really fantastic, Michelle. I just really appreciated it. And I have been a strong, ACS has been a strong partner on so many different levels, both as a role as a physician and helping to care for patients. As a researcher, one of my first grants was really looking at disparities related to endometrial cancer in Black women. And so this is just really, I don't want to sound like too much like a cheerleader for what ACS does, but I really, Michelle, you really kind of hit all of the high spots in terms of this link and the continuum. And that's what I'm going to talk a little bit about today. I promised Chris that I would get through my slides and leave a lot of time for questions. So next slide, please. So we've talked about defining health equity, and I think one of the things that I always like to think about is that health disparities and that some of the data that I'm going to present today is really the metric that we're using to measure our progress, right? So like, are we seeing differences in these outcomes, and what are our metrics? I think the person in the chat who asked that question, I think this is really critically important to sort of hold ourselves to be both very transparent and accountable, and also accountable to you guys who are the people who are doing the hard work of like, the fundraising, the boots on the ground for getting money to do all of these programming is like critically important, and sort of spreading the awareness about this as well. So next slide. So I want to kind of go through some specifics about health disparities in Chicago and Cook County to really ground this and center this in where a lot of the work gets done. We can kind of talk briefly about sort of causes and inequities, but I think Michelle has covered that really well. But just thinking through about like how Chicago is a segregated communities, right? Like, the racial and economic segregation that we have, the redlining that historically created a lot of this, in terms of thinking about access points to care and screening, follow-up, and specialty cancer care. That's also a really important part, because sort of the geography of where people are located, as well as the geography of their insurance. So you may be sitting next to Northwestern and University of Chicago, but you may not be able to access them. Geographically, you can see them, right, from your backyard or whatever it is. But if your insurance isn't the right insurance, you may not be able to get your cancer care at a NCI designated comprehensive cancer center. So we really need to think about how we improve the quality across the board, and also how we do have access points to care for those who need them. And I think this is really a question of like, how do we move beyond describing the problem, which has been described for 30 years, 40 years in terms of people who are in the disparity space, and moving towards this equity space. And one of the ways that I'd like to think about this is like thinking about equity as a quality measure, and how do we embed that in systems as well. Next slide. So this is the cancer care control continuum that I think Michelle commented on as well. So thinking about like etiology, prevention, detection, diagnosis, and that detection to diagnosis linkages. This is where a lot of lay navigation, a lot of navigation that our community partners that work with ACS do, and thinking about these cross-cutting areas that have been defined as like, where can we make a difference, both in terms of research and implementation. And I'd like you to keep those in mind, because many of you may be coming to your role on this board because of a personal connection to cancer, or a cancer survivor experience yourself, or a family member, and thinking about like, where are those impacts, and where can you make an impact beyond what you where you are as well. Next slide. So when we think about I have kind of some slides that we use sort of sometimes in our own catchment area and from University of Chicago, but really looking at Cook County and kind of some of our surrounding areas, we know that there is a segregation by race in terms of like the dominant race groups in different locations. We know that is also matched, unfortunately, by things such as like income and median household income and poverty. Next slide. And when we take like a deep dive and we look at the neighborhoods that we're really looking at through Cook County, this is where we start to see some of these differences as well in terms of household income as well. Next slide. Keep going. And then we can look at the, where we're located. We can look at these different things. That was the hardship index, which is something that one of the things that I love, and those of you who know me on this this call know that I really love to look at the Chicago Health Atlas, which is another wonderful resource for looking at data and neighborhood level data. And they have a combined score of hardship that really includes a lot of different measures, including poverty, employment, education, different things like that. And we see where this, matches what we see in terms of the racial and economic differences. Next slide. This is potential breakdowns in care coordination across the care control continuum, right? So this is where a lot of the actions and the really concrete examples that Michelle gave, we really look at like, where are we seeing lack of access of risk assessment and behavior, screening recommendation and opportunities for screening. All of these these lines are really important to kind of think about where we have opportunities to think about health equity interventions and to think about where we have gaps as well in terms of what we can do better. And this is kind of where the measurement comes in as well. So each of these little like pods has their own way of measuring, and we may be measuring at the neighborhood level, but we may be actually measuring at the clinic level or the institution level. Like right now we're doing a project looking at like the ability of cervical cancer screening to transmit to actually getting the early diagnosis, right? So we have a lot of women getting screened in FQHCs, but we have no-show rates for follow-up for abnormal pap smears that are as high as 50 to 60%. And that's really like, we can pat ourselves on the back because we have 80% sort screening, but if we're really not doing anything with that screening and follow-up, there's a gap there that we want to reach, right? Next slide. So when we look at like types of cancers in Illinois, and just in terms of like what's most common, we think about breast, prostate, lung, colorectal, uterine cancer. Those are some of the more common cancers that we're seeing. Next slide. And when we look at cancer deaths, we see also a difference in terms of lung cancer, breast, prostate, colorectal, still being up there in terms of like the ones that we're seeing the highest numbers of deaths. But as we know, this is not always equally distributed. Next slide. When we look at Cook County and we look at kind of rates of new cancers by sex and race and ethnicity, we see that there is a difference in men in particular, between Black men and white men in terms of their diagnosis of just all cancers combined. And we see a more subtle difference between Black women and white women here as well. But when you go to your next level of data, next slide, please. We can really see that there's disparities in diagnosis of these screenable cancers, right? So this is an example of where things are not all as equal, right? So geographically, the darker shaded, I'm sorry that I didn't include the incidence rates here, but I can get those for you for those who want them. When you look at neighborhoods that have a darker blue, the darkest blue is the highest incidence rates. And as you go into the green and the shadow gets lighter, those are lesser rates, high rates per 100,000. And when we look at like neighborhoods where we see screenable cancer incidents really being geographically segregated, we know the communities that we really need to be working on and establishing where we can make a difference there. And again, some of the things that Michelle mentioned as well. Next slide. When we look at deaths in Cook County for breast cancer, and this is something that we, think about, like, the detail, is so important. When we look at incidence rates, and it doesn't look as strikingly different, right? 131 per 100,000 versus 138 per 100,000. But look at the death rate for Black women compared to white women in Cook County. And a lot of this has to do with a combination of things: early detection, access to quality mammograms and quality screening, because all screening may not be equal. And that's really something important that a lot of researchers are diving into as well. Also, age of diagnosis. So women who are diagnosed before the age of like standard population-based screening, right? Incidence of cancer genetic testing, so that all women are equally getting access to genetic testing, so we know who to screen earlier. These are all things that are just, and a whole host of other things that can contribute to this really wide gap. Next slide. When we look at incidence and mortality over time, we see that like from 2000 to 2017, have we seen kind of a slow change in Black women in incidence? Yes, but do we still see a large gap? Yes, right? So we also see an uptake in Asian communities of having increasing breast cancer incidence. So we really are kind of like juggling a lot of different things to think about how we get things, everybody improving, but also lowering this gap between how different groups are doing. Next slide. This is the same for prostate cancer. When you look at men and prostate cancer, it's a very controversial area. There's a lot of press out there that like, oh, prostate cancer is not that bad. And, prostate cancer is overly diagnosed, but it's not overly diagnosed in Black men, right? So this is a different thing. The idea of like, who should be screened and when really needs to be targeted to which populations we're looking at. And this is another really striking example about the death rate for men in the Cook County area for Black men versus white men for prostate. And so this is really where we have to like have research both at like the molecular level, at the screening level, and at the education level, because we're not going to be able to say that it's a one size fits all criteria for prostate, for example. As you can see, I could get into a lot of the details of this, and anybody who's more interested, there's plenty of work to be done in any of these topics. So next slide. Again, just bringing back again, where can we make an intervention? Next slide. I'm going to deep dive a little bit into lung cancer in particular. So we look at the big map and we say, okay, Illinois is in the middle of everything. We're sort of seeing the US overall incidence and mortality, and we see Illinois is a little bit higher, but kind of around the same. Next slide. But when we take a deep dive into the incidence and mortality at the level of our communities, we see striking, like some of these are 100 per 100,000. And that's strikingly different than what it is at the US level, right? And we see that we see differences in our populations as well. Next slide. So when we're thinking about health equity in cancer, we know we have documented disparities, but we need to think about access for screening. So lung cancer is actually a cancer that we can screen for, but probably only 25% of people who would be eligible for screening get screened, essentially. We have the bias and stigma of a lung cancer diagnosis. We have the social determinants of health. We know that this matches like tobacco and vaping rates as well. We have bias towards lung cancer because people blame patients who get lung cancer, unlike other cancers that are not often as blamed, quote unquote, whether or not you're a smoker or not, that bias exists. But there's also the access to biomarker testing, because the research is that patients who get lung cancer really need to have this genetic biomarker testing done to see if they can access new technology and new treatments. But if they're not tested, then that's a huge problem, right? So ACS was really involved with some of the legislature at the state level to require Medicaid to be able to have biomarker testing, right? So this is a really important issue. Access to care in clinical trials, another legislative and policy point. And so these are kinds of things about how you take like what you know about one cancer and really kind of take it through that trajectory about where people want to put their passion and their energy into working on, right? You may want to do it at the policy level. You may want to do it at the screening level, and really picking your area of what you want to focus in on. And like really, I'm sure, Chris would be happy to kind of, let you take it and run if there's an area you want to work on. Next slide. This is a little bit on clinical trials. We know that this is an ongoing issue with clinical trial enrollment and the lack of minority participation. So if we're not enrolling minorities that represent who gets the cancer in the trials who on treatment, we're not going to see the same effect when I'm taking that drug and applying it to my patient. Next slide. So thinking about community-based infrastructure, like how do we make this change? So utilizing patient and community partners, infrastructure to assess like specific community concerns, review of the data, review of needs assessments at the community level. So we have a strong community advisory board at our cancer center. We have a lot of active partners, including ACS. We have a clinical trials working group. We have a Latinx task force that's really active now, and a policy working group. And we're also really embedded with the Illinois Comprehensive Cancer Control Plan, as is ACS, to really make this a state level issue. Next slide. I'm going to skip over this one, but next slide. And I'll skip this one too, so we can leave time for questions. This is a really interesting model. So when we're thinking about how we make change and we think about not just being in a box of like, hey, let's have the equity people over here and do the work and disparities on this side, and then we have the quality people who are looking at change on the other side, this idea of quality as a goal. So traditionally people have talked about like in healthcare systems, we've talked about improving population health, enhancing healthcare experiences, reducing costs, and addressing provider and caregiver burnout. But this fifth aim of really achieving and prioritizing health equity is getting a lot more press now, and kind of decision making about what are the, obviously we've done a lot to document and find the disparities, but how are we integrating these evidence-based interventions, and how are we really like putting like our money where our, you know, our talk is, in terms of like investing in measuring the equity goals at the institutions and really incentivizing if you achieve those goals, right? So this is things that we're thinking about at the clinic level, at the section level, at the department level, and at the institution level. And so those are kinds of things that we can think of, like, you know, depending on where people want to work, you can kind of think about where you could fit in this equity lens that we started the conversation with. Next slide. This is kind of a slide that I like from AACR, because it really thinks about like, think about where you fit into this, right? So where do you fit in, like as somebody who is a, you know, whether you're a institutional leader, whether you're an advocate and you're thinking about disease awareness, funding, you know, funding our future scientists. So you can really think about how this, like this sort of ecosystem fits in together, and really thinking about where ACS fits in. Obviously they hit on all of these points, quite honestly, but thinking about your own role in cancer advocacy is really important, and thinking about where you'd like to fit in through this is a great opportunity. And we're always looking for more people who want to partner with us as well. So thank you. I mean, I did a whirlwind, but I hopefully got time for questions.
Thank you, Dr. Lee, for the overview of how cancer inequities and that demographic breakout is reflected in the Chicago area. I'd like to formally invite anyone to type in their questions in the chat. Chris is going to help us kind of feel through some of those questions. While you're thinking through that and typing through, I'll tee up one that I had for you, Dr. Lee. You referenced you know, kind of where we can fit in, and for those on this call and those who will see the future recorded call, recording of your messaging, mention, you know, where can we fit in? How can I'll label myself ordinary person, working mother. Yes, I volunteer with ABOA, ACS, but how can I leverage my professional network, advocate my personal network? How do we operationalize the research? What can we do as individuals and scale that up?
I mean, I think you can really do so much at different levels. Like, I mean, if you think about it, like, you know, there's like such great intervention that you know, we have like a University of Chicago, like moms group, for example, right? So like we even have that in a professional level, and those organizations like are really helpful for getting the word out on certain things, right? So it may be like thinking about, what are you doing in your own organization for screening and awareness for cervical and breast cancer, for example, right? So like it's like target age, reproductive age women, right? Or a little bit older. But so you can think about like, what are you doing in your own social networks at work first, right? I mean, some of this is like really asking, like, are my family members getting screened? Like, did I even like know if they got this, or, you know, so those measures may seem small, but it is amazing by word of mouth, because a lot of times, like, that's going to be the thing that actually says, okay, like maybe we should do this, right? Like my husband yesterday went to his primary care doctor. He's like, do I really have to ask about colorectal cancer screening? I was like, yes, you have to ask about colorectal cancer screening, right? But it's easy for me in our busy lives to forget about that. I think the issue is also like, you know, the time commitment, like where you have the time. So thinking about things that maybe already blend into existing structures to share the data can sometimes be very, very helpful. And then thinking about like other community organizations that maybe sort of like need like help with certain things that you're really good at, right? Like we have organizations that, like, you know, when COVID first started, they had never done Zoom, they had no idea. So a lot of what we did was like really just helping people like get onto Zoom, right? Like, or to like organize things. So thinking about what your skill set is, there's a lot of organizations who would love the help with like spreadsheets and like organizing their systems of like, you know, their fundraising systems. And so those are kinds of things that you could do if you have like a little more time. If you're somebody who likes to like, you know, fundraise on a different level. Like, so it kind of depends on like what you would want to do, right? Like, or do you want somebody to be like, you want to be more engaged with a more grassroots organization that's really doing navigation, right? And you can say, I can do navigation or phone navigation one day a month, right? So it sort of depends on like what you'd want to do.
Perfect. Thank you. I don't see any questions yet from the chat, but I'd like to ask one final question. Well, actually, hold on. We did have one. Go ahead, Chris.
Yeah, do you mind if I hop in here really quick?
Yeah.
I saw Jeff. Yeah, so Jeff, I saw your question here about ABOA metrics, and I wanted to provide a little bit of context, if that's okay. So the associate board, and this kind of gets into our final section about next steps, how you can get involved. The associate board at its core is a fundraising group of volunteers for the American Cancer Society, but we also embody the mission of the American Cancer Society and carry those principles throughout our daily lives and within our network. So some examples of how we contribute to this are we run health return to screening campaigns. So we encourage all of our members to attend a health screening of some sort throughout the year, and we ask them to share with us when they attend that screening. They don't need to tell us what type of screening, they don't need to tell us any feedback, personal medical information, but we just started doing that last year, and we had 50% of our members attend a screening, which was great for a first year campaign in partnership with Cigna. We're doing that again this year and encouraging our members to get back to screening. All of the sponsorship funds that we raised this year are being allocated to health equity and the American Cancer Society Health Equity and Research Operations Campaign, also known as HERO. When I follow up, I'll actually attach a one-pager about what health equity results the American Cancer Society has contributed towards here locally in Illinois. Also, we fundraise through our personal fundraising pages, and all of those funds go to a local cancer research grant here in Chicago. We actually just announced this last month. We're partnering with Dr. Mandello at Northwestern University and his breast cancer research lab. So again, like Dr. Lee was talking about with the breast cancer rates, you know, his specific project is hopefully going to contribute to the overall rates of breast cancer and supporting minority populations so there are less diagnoses in the future. These are just a few ways of how the ABOA is contributing to health equity and various campaigns, and how we encourage our members to take ownership of their own health and well-being as well. Autumn, sorry to jump in there, but
thank you. No, perfect. Thank you. You answered that way better than I could have articulated, so thank you. I would like to, with our 7 minutes left, I would really just like to give a final thank you for your time, your expertise, and for calling out the next, call to action in terms of what's needed in order to achieve the mission and the goals of reducing cancer mortality rates by 50% by year 2045. The way that we can do that, though, is to reduce the inequities in certain populations. It's the only way that we would achieve that goal. And so raising awareness through the expertise of Michelle Turner-Hicks and Dr. Lee. Thank you for your time. Really appreciate you joining us. I'm going to ask Emily Fitzgerald, ABOA's president, if you could close us out with the final words.
Hi, everybody. Thank you so much for joining us, and sorry for the background noise. COVID closures have all 3 kids home from school. But thank you for being here. Our action items, number 1, join the ABOA, but if you cannot, please nominate someone to join who you think would make an impact in the Chicago community. We are a fun group, and we are making a huge impact with our fundraising every year. We welcome you to volunteer in different areas. ACS has so many areas to volunteer in, so if ABOA is not your thing, pick one that you're passionate about. And if you'd like to learn more, visit cancer.org, or you are very welcome to reach out to me, Emily Fitzgerald, attorney at Swanson Martin & Bell, easy to find the contact information or through Chris. I know Autumn would be happy to speak with you as well too about the board and what you and your company can do to get more involved. We're just thrilled to have you all here today. So thank you so much. And I hope everybody has a good day.
Awesome. Autumn, any final words?
Yeah, thank you all for joining us. Really appreciate the time. Share the recording with your friends, family members, and your professional network. And really appreciate you joining us today. Have a great rest of your week.
All right. Thank you, everyone.
Thanks so much, everyone.